Okay, so we're continuing on our sort of basics of male hormones, particularly testosterone is our sort of our main topic, and we're talking about the complications that we see. So, male pattern hair loss and benign and prostatic hypertrophy. So it comes from the conversion of testosterone to dihydrotestosterone. That's sort of the super testosterone, and that's where most of the physiologic and complications from testosterone come from, is the dihydrotestosterone. So in 1947, this Dr. James Hamilton from Yale did a study, and he concluded that it was dihydrotestosterone that was the main culprit for acne, hair loss, and benign prostatic hypertrophy. And dihydrotestosterone shortens the hair cycle, and you get hair miniaturization. You also get some scalp blood decrease in scalp blood flow. And that's the reason why we can't put testosterone, if you take the cream and you put it on your scalp, it's going to make your hair thinner, not thicker, unfortunately. You have to put it on below the eyebrows. That's the DHT is much less from the eyebrows down than from the eyebrows up. So again, whoever put us together, played a big joke on us, with that. So then in 1974, notice the symmetry here, 47, 74. This Dr. Julian Perito McKinley went to the Caribbean. She found this sort of tribe of natives, and they had genetic 5-alpha reductase deficiencies. They all had bushy heads of hair, no prostate issues, but they had high rates of anxiety and panic disorders. Now, why would that be? You should know this by now. Okay, so again, male characteristics are stimulated by the conversion of 5-alpha reductase of testosterone to dihydrotestosterone, and we see an increase in facial hair, deepening of the voice, muscle growth, and prostate enlargement. Rising scalp DHT is linked to male pattern hair loss. Rising body DHT results in body hair growth. So if we put again, the testosterone will convert to dihydrotestosterone. If you put it on the body, you're going to get hair. If you put it on the head, you're going to lose hair. Those that have been castrated for whatever reason do not go bald. And 5-alpha reductase inhibitors slows hair growth, but hair loss recovery is incomplete. Usually you only get about a 30 to 40% recovery of hair, but it stops the hair from coming out. Dihydrotestosterone upregulates interleukin-6, which inhibits the hair shaft follicles from elongating and suppresses the proliferation of the matrix cells in hair follicles. So again, an anti-interleukin-6 would be of a help. So in 1992, the FDA approved MK906 by Merck, which was a synthetic transition state inhibitor, and it competitively inhibited types 2 and 3 alpha reductase. There are 3 types of 5-alpha reductase inhibitors, 1, 2, and 3. And the Merck brand Finasteride inhibits types 2 and 3. It's about 70% effective in decreasing serum DHT. And it decreases prostatic DHT by 90%. So, when we draw a DHT level, you're getting the serum. So you're not getting the whole picture. Because it's you have to add an extra 20% to sort of get the whole picture of your tissue DHT. Dutasteride, which came out in 2002, I think, blocks all 3 5-alpha reductase inhibitors, and that's a 98% block of DHT. So finasteride is Proscar in a 5 milligram dose. Dutasteride, forget what the brand name is. You know what it is?
Dutasteride. No,
I forget. Okay. Anyway, it's a 0.5. Oh, Avodart. That's what it is. That's my low pregnenolone levels. Yeah. It comes to me eventually. Avodart, 0.5 milligrams, and it decreases DHT by 98%, which sounds like a good thing. Here's the package insert: indications for finasteride, benign prostatic hypertrophy, and androgenic alopecia. 5 milligrams for benign prostatic hypertrophy, 1 milligram for androgenic alopecia. 5 milligrams, the brand is Proscar, 1 milligrams is Propecia. Off-label for women, you can give them 2.5 to 5 milligrams. You can use it with an oral contraceptive. If it's oral contraceptives after 6 months are ineffective for hair, again, stopping hair loss. That's the first objective. The second hair is some hair regrowth. You can use it initially, as initial therapy if they're infertile, and you can use it as a cellulite cream with 1% testosterone. You can have that compounded. Side effects, and again, this is the official package insert. Infertility, 34% decrease in sperm count, 14.5% decrease in sperm volume after 26 weeks. After discontinuation of use, there's the package insert says that seminal quality returns. Sexual dysfunction, impotence 5 to 8%, decreased libido 2.5 to 6%, decreased ejaculatory volume 1 to 3%, ejaculation disorders less than 1%, and some breast tissue dysfunction at 0.9 to 2.5%. So those are the side effects, and we're gonna actually show you why that happens. So these are laboratory changes after 3 months with finasteride. So testosterone and estrogen levels increase by about 15%. And so if you get a testosterone level, say of 500, and they're on finasteride, you have to take 15% on. That's off. That's the true testosterone level. Pregnenolone, vitamin D, zinc, insulin and insulin resistance increase, fasting blood sugars and hemoglobin A1Cs increase. On the flip side, progesterone drops by 90%. DHT, of course, drops anywhere from 60 to 98%. PSA is down by 50%. So, you draw a PSA, you have to remember it's actually twice whatever your reading is. So if you get a 2, it's really 4. Okay, and there was some hysteria there about missing prostate cancers because we're seeing low PSAs and it's artificially low. And you get a decrease in FSH and LH, and that's where you get your decrease in your fertility. Increase, again, so the decrease in FSH and LH results in decrease in insulin sensitivity, decrease in production of allopregnenolone GABA, and you get a worsening of semen analysis. Okay, so if you go onto a search engine and type in post-finasteride syndrome, you're going to get a blizzard of things. Have you heard of this? Have we talked about this before?
We have not. No, sir. This is
This
is new, sir. We have not.
Oh, okay. All right. So, so finasteride, unfortunately, for a small subset of usually men, young men, taking the 1 milligram, can have some really devastating side effects that a lot of times are permanent, and they don't go away. And of course, I actually have a whole lecture on this. The urologist, of course, said, what are you talking about? You stop the drug, you go back to where you were. Well, actually, no. It's called post-finasteride syndrome. It was actually recognized as almost as soon as the medication came out, but of course the company denied anything, there was anything. It was just temporary. It was all in their head. Then it became an internet phenomena. But there's actually physiological reasons why this should happen. So here are the symptoms first. So there's three sets. There's sexual side effects, one they call general side effects, and then there are psychological and psychiatric side effects. So the sexual side effects are what we already talked about a little bit. Decreased semen volume, decreased semen force, loss of spontaneous erections, decreased libido, erectile dysfunction, impotence, Peyronie's disease, sexual anodidia, and loss of pleasurable orgasm. Now, remember, why should that happen? Remember what we're doing. We're blocking testosterone converting to dihydrotestosterone. That's where, you know, most of the effects, good or bad, of testosterone happen. So if you take away the dihydrotestosterone, you're going to start seeing some of these symptoms. You know, if you're fortunate and it's not too severe or not at all, that's great. But it happens mostly in young guys. You know, old guys, you know, like me, you know, we're just happy to not have to get up 3 times, 4 times in the middle of the night. You know, whether anything else works, well, you know, that's a bonus. You're not quite there yet, but trust me on this. Okay, so those are the sexual side effects. The general side effects, I want you to see if you can pick out what this sounds like. Fatigue, dry skin, dry hair, fingernails crack and break, redness in the face, ringing in the ears, gynecomastia, muscle weakness, decreased muscle tone, increased fat, especially belly fat, increased BMI, increased blood sugar, increased triglycerides, decreased body temperature. So what does that sound like?
It sounds like you know, thyroid disease.
That's great. You got it. That's one. And the other one is really you know, a lot of some of these symptoms are of decreased estrogen, or increased estrogen, decreased testosterone, right? Belly fat, obesity, gynecomastia, right? Muscle atrophy, muscle weakness. So, you know, what are we doing? We're blocking you know, you're getting an overabundance of estrogen is what it is. So yeah. So yeah, thyroid disease. And the key for me here, picked it out, was this: decreased body temperature. And then look at the other thing: dry skin, dry hair, right? Chronic fatigue. And then apathy, you know, is testosterone, low testosterone also. So, okay, you got it. You're getting there. Very good. And then the neurological symptoms, and these can be the most devastating. Memory, severe memory and recall impaired, decreased problem solving, decreased comprehension, anxiety, depression, insomnia, emotional flatness, suicide ideation. What does that sound like?
Remember, recall, impaired problem solving, anxiety, depression, early onset dementia syndromes, psychiatric illness, you know.
Yeah, well, in our hormone world.
Growth hormone deficiency.
There you go. You got it. There you go. Okay, that's exactly what it sounds like, right? And a little bit of testosterone, also anxiety, depression, anodidia, emotional flatness. So yeah, and suicide. So yeah, okay. So sounds like testosterone disruption, thyroid disruption, and growth hormone disruption. That's what it is.
Yes.
And of course, the you know, the big shots, they'll say, what are you talking about? That's craziness. So this is the I've showed you this one before. I showed you the other one. This is the steroidogenic pathway, you know, cholesterol to pregnenolone to DHT to testosterone. Here's that 5-alpha reductase. So testosterone converts to dihydrotestosterone, and this is what we're blocking here, right? And remember, testosterone goes to estrogen. It'd be over here over on the right. And remember, so when you block this, you're going to get an increase in testosterone. We noticed by 15%. Remember, I told you just a couple of slides ago. And you're going to get an increase in estrogen. Correct?
Yes, that's right.
Okay.
Exactly.
All right. Now let's look over here on the left. Progesterone converts to 5-alpha dihydroprogesterone. Testosterone, dihydrotestosterone, progesterone, dihydroprogesterone. Dihydroprogesterone converts to allopregnenolone. And allopregnenolone, if you'll recall, is what stimulates the GABA receptors to produce GABA, your calming neurotransmitter. Correct?
Yep, that's it. Yes, sir.
Right. Look at the enzyme that converts progesterone to dihydroprogesterone. See it over here?
5-alpha reductase. Yes.
Exactly. You're blocking 5-alpha reductase. Guess what's going to happen here? That ain't going to happen, right?
That's right.
You're blocking the substrate for GABA, your calming neurotransmitter. How do the benzos work? How does Valium work? Xanax, all of them. How do they work? What do they do? What's their mechanism?
Gosh, that's pretty pathetic from he who writes for them all the time.
Yeah.
But I'm sorry, I don't know. I don't know what the biochemical mechanism of the
You should know that. You write for them all the time, right?
Oh, I should. Yes.
Right. Okay. So the benzos bypass all of this and directly stimulate allopregnenolone to make GABA. That's how they work. Okay. So did you ever take one yourself? See what happens,
No, I've never had one. No.
Yeah, I had a couple of times. I did during the divorce. I did a couple of times. So, kind of mellows you out. The problem is, as you know, one, it's addicting. Two, there's a lot of drug interactions with it. So it would behoove us to get away, have a nice way to increase allopregnenolone, stimulate it without, something that's addicting and has drug interactions. So one way to do it, and you have to do it you can only do it for a short term because because you get some side effects from it, is you can greatly increase pregnenolone up here. And by greatly increase, I said we use about 400 milligrams daily for you can use it up to about 4 weeks. Okay.
Yes,
and
sir.
that will drive this reaction to greatly increase your GABA output. All right. And remember, our pregnenolone is our hormone of memory, so you're loading that up also. Now, there are now 2 synthetic allopregnenolone drugs that are FDA approved. The first one was approved in 2019, and it's called, I think it's called brexanolone. I can look it up. Okay. It's made by a company called Sage Therapeutics, and it's synthetic allopregnenolone. They made it in an IV form and in an oral form. The problem with the oral form is there was a side effect of sudden loss of consciousness, which is not a good thing if you're driving, So it was only released in 2019 as an intravenous form, and it was for inpatient only for postpartum depression. And it was pretty effective as far as postpartum depression. It's a 60-hour continuous IV infusion, and it's about according to the statistics, about 60% more effective than just the SSRIs and SNRIs and the usual stuff. So it's pretty effective. It works pretty quickly. Again, the problem is it's an IV infusion, and you can't get the sudden loss of consciousness. So in an IV infusion, it has to be done in an inpatient setting, so the loss of consciousness isn't so terrible. And it was, and the only other issue is that it's $34,000 for the drug. So,
Wow.
of course, right? So this summer, the company got in fact, just in August, the company got their oral form approved for postpartum depression and for MDD, which I forget what that is. You know what that is?
MDD, major depressive disorder.
Yeah. Yeah. And it was approved in an oral form. So we were wondering how it was going to get around the sudden loss of consciousness. And there's a black box warning on it. So it's still there, but there's a black box warning on it saying that if you take this drug, you cannot drive for 10 hours afterwards. So, if you take it in the morning, you can't drive all day.
Oh,
okay. But what it is, it's synthetic allopregnanolone. The trade name is Zuroxolone, I believe. Zuroxolne. I might be off on that a little bit. I can look that up. Okay. So when you block this 5-alpha reductase, you can get a loss of allopregnanolone, a loss of GABA, and we end up with remember, L-glutamine. L-glutamine is your activating neurotransmitter. So you get an imbalance in the neurotransmitter. So the patients get wild. Here's that pathway again: progesterone to 5-alpha dihydroprogesterone. We're blocking the 5-alpha reductase inhibitors. Here are the symptoms of a decrease in GABA and the so-called post-finasteride syndrome. So when we block or decrease GABA production, we see all of these things. So memory loss, slow thought process, mood changes, impulse aggression, anxiety, depression, suicide ideation, insomnia, emotional flatness. Basically, your loss of your calming neurotransmitter. And this post-finasteride syndrome, as you can see, they're pretty much all the symptoms are all pretty much the same. There's a aggression here and Parkinson's-like syndrome here. All the other ones all match. So this is the mechanism. This is what happens with that. There's also been quite a number of suicides that have been attached to, traced back to the beginnings of taking finasteride. Usually in young men, ages 18 to 45, 1 milligram. They've taken it for 6 months. This was from 98 to 2013, 4,900 adverse effects were recorded, suicide ideation rate of 0.7%, which doesn't sound like a whole lot, but, a guy's trying to save his hair and now all of a sudden he's suicidal. That's not great. So most of them had some sort of concomitant depression and insomnia. So anybody who's got those kinds of symptoms in their background, you pretty much should stay away from this drug. 11% or almost 12% suffered from persistent sexual dysfunction. This is before taking the drug. 8% harbored suicide thoughts. 15% had suicidal thoughts, completed suicide. That's on the drug. So it's it's not a nothing. And so from 2011 to whenever I did this, 2021, 700 reports of suicide ideation, 356 deaths, 63% increased incidence versus a non-treated, matched population. From 97 to 2010, there were 34 reports of suicide ideation, 10 reports of completion. 4 times the incidence of depression and anxiety versus the non-treated population. And of course, the manufacturer says premature hair loss is associated with low self-esteem and poor body image. It's their fault, right? And depression. Okay. And it seems that suicide's more common with the lower dose than the higher dose. So it's something you should need to be, especially if you ever prescribe this stuff?
What do you mean that?
Finasteride? Or
Yes, I have, but much less since looking at the data on post-finasteride syndrome. I'm really concerned about using it, at all anymore. So I
yeah.
try and
Lower doses, it seems to be dose dependent also. So we've been using so when we do hair, there's a genetic test we do from GX Sciences.
how is that working for patients? Is it good?
Yeah, it gives me a guideline of what to use, what to treat them with. I mean, it's $275, but for the patient, but it gives us a treatment guideline. A lot of times they'll put in, they'll give you a lotion, and then they'll give you what they call, what they want you to do is compound a capsule, and a lot of times they'll put in dutasteride or finasteride. But what we'll do is we'll use 1/3 the dose. So we'll use finasteride 1 milligram 3 times a week instead of every day. And so far, I really haven't. It's been better as far as side effects. Okay.
Yes, sir.
Okay. We can do hair. Did we ever do hair? We can do. I got a lecture on hair.
No, we need to do that. No, we have not. Not yet.
All right.
I'm curious. Have you had any? Have they looked at the 2nd generation 5-alpha reductase inhibitors like dutasteride versus finasteride in terms of the degree of their side effects and safety? Is dutasteride safer in any way than finasteride, or?
Actually, I think it's the other way around. Remember, dutesteride's 98% DHT block, finasteride 70%.
Okay.
Yeah, they just call it finasteride syndrome. Okay, so I don't know, which test do you use for testosterone? There's total, there's free, there's bioavailable.
Total and free.
Yeah, there's so we get the sex hormone binding globulin, and we do that calculation, and we get a free androgen index. There's salivary tests, there's urine tests. The problem with the salivary and urine tests is that they're not covered by any insurance, and they're kind of expensive. So you should get it in the morning before 10 a.m., especially for the total. Most of the insurance companies want you to do 2 of them. If it's 302 and they have every symptom, that's normal. They're not interested. I don't know if you've ever run into that.
No, sir.
Huh?
No.
Well, we get it all the time. Check a LH, luteinizing hormone, check for secondary causes. If it's low, that it could be a total pituitary issue. For fertility, you need a semen analysis. A DEXA scan somewhere along the line. If it's less than 150 total testosterone, remember that's our 147.5 is our depression cutoff. You need to check prolactin and pituitary, and then chromosomal studies. If it's sort of a lifelong thing.
Yeah, I sent a guy to endomedicine the other day, and it told a testosterone of 60.
Wow.
60.
Mm-hmm. Yeah, I had a guy who was 89. So 25-year-old male produces anywhere from 4 to almost 12 milligrams per day. Just in my head, I'll use 10. That makes it easy. So when we do pellets, that's how I figure it. So 10 milligrams per day. If we use 1,400 milligrams, it should last 140 days. Your shot, 200 milligrams IM per week. That'll give you a super physiologic dose and an increased DHT and estrogen. So it doesn't mean that I don't do it, especially if they're symptomatic, but just keep in mind that, they're making anywhere from 4, which with 4 times 7 is 28 milligrams, to 12, which was 84. So that's physiologic at age 25. Just keep in mind that a 200 milligram, a 1 CCIM is almost 3 times the physiologic doses. So here are testosterone replacements. There's a couple on here, that newer ones that I don't have on here. So clomiphene, now you can't get it at a generic, but we get it from Anazao at a 45 milligram tablet. They charge us $2 a pill for it. Before the generic was 60 to 70 cents a pill. And then there's a company now I keep getting in the mail that they've taken over Clomid, so I'm sure they're charging $15 a pill. So I don't know what your experience is with that, but
we have Clomid and clomiphene, and I don't know where Viking is, sourcing their stuff from. Sam gets these great, I don't know where, they may be paying a fortune for it. I have no idea, but I can find out. We just added enclomiphene only because patients were asking for, decrying about, about enclomiphene. I don't know. I guess it's coming from the performance enhancing drug world. The juice bags are using more enclomiphene.
right, I know. Yeah, I know. We get that. Okay, so there's these are the trade names. Androgel, I never use them. They're all synthetics, and you're going to get high DHT levels and higher estrogen levels, and they cost a fortune. The insurance will cover it. It's $75 a month for a copay usually, and it's who needs it? I think Testum is now off the market. I'm pretty sure about that. The injectable cypionate is a 12-day half-life. Ethionate is a 10-day half-life. Propionate is a 36-hour half-life. So I know Dr. Gordon makes a combination of propionate and cypionate. So he gets a short-acting, long-acting one. He likes doing that. He also gives Clomid twice a week, and that's kind of his regimen. And I don't know if you dealt with Dr. Gordon. He's always right. Just ask him. Okay. Right. He also is on Joe Rogan saying that he's using 50,000 units of vitamin D every day. And I showed you that, didn't I?
No, I did not see that.
Yeah, and Joe Rogan says, "Wow, that's a lot." He goes, "Why?" And Gordon says, "Why? Who says who?" So I wrote him about I've told you about my patient who killed himself with the vitamin D.
No.
I didn't tell you about Tom?
No.
All right. So let me just get through this and I'll tell you about Tom. So there's a couple of new ones on the block. Testosterone undecanate is a pill form, and it's supposed to go through the lymphatic system. It's supposed to bypass the liver. You're not supposed to get the hepatic issues that you get with testosterone, orally. It's pretty expensive. You have to use it twice a day.
I thought there was a once a month or once every.
That's the injectable form.
Yeah,
this is a pill form. This just came. This has only been out about 3 months.
Oh wow! Okay.
And then there's a nose spray, Natesto, I think it's called. It's 3 times a day, and you get sinus issues, and it's also $1,000 a month.
Now, let's see. Have you used that, sir?
No, these are ridiculously expensive. I mean, what's the point?
Yeah, that's right.
I mean, if somebody wants them, I'll write for them, but I'm not gonna. So, can I? I'm going to. I need to take a break for a minute. Okay.
Yes, sir.
Okay. Actually, it's getting to be kind of late. I'm going to have to get going here in a few minutes. Okay.
No problem at all, sir. Yes, sir. That's fine.
Okay. So testosterone replacement, the creams and gels take 4 to 8 weeks. The injectables take 4 weeks. The pellets take 4 to 7 days. Okay. I'm not sure about the newer, medications and the nose spray. So that'll be your homework assignment for this week. Okay.
I will look. Yes, sir.
Okay. I know a lot of this is a review. Is this a help or no?
Oh, yes. No, it's great, sir. Absolutely. Wonderful.
Okay. Oral never. Well, we got that newer one that I just talked about. It's hepatotoxic. There are some sublingual ones. You have to use them 2, 3, 4 times a day. They wear off quickly. The transdermal commercial products are usually 1 to 2%. That's usually what we do for women. They are quite expensive. I mean, the Androgel is $400 a month without insurance. Compounded ones, we usually do 10 to 20% concentrations. We can put it in a hypoallergenic base. And I'm sure you have you have a compounder that you like that you use all the time.
Yeah, well, we use 3. Hollandale is the big one, and then Create Aid and New BioAge, and excuse me, there's 2 others: Rite Aid in San Antonio, and Revivex. We're also using them, and Progress Pharmacy. Forgive me, those ones.
Yeah. Okay. So the injectables. So the VA will give them the injectables every 2 to 4 weeks. Well, that the injectables half-life is, depending on which one you use. Again, ethynate is 10 days, cypionate is 12 days. So you're basically almost starting all over again if you give it 2 weeks. And if you're starting at 4 weeks, giving them every 4 weeks, you are starting all over again. If you split the dose and give them 2 shots a week, you get less aromatase activity, and then you just have to, just the way it is, and they have to get over their needle fear. Okay, here's that undeconate injectable. Has a 12-week half-life. It has a hydrophilic side chain and has a castor oil carrier. After you give the shot, the patient has to you have to have the patient wait around at least a half hour. So you would do this in the office. We don't do this. It's you give the shot on day 1. You give a second shot 4 weeks later, and then after that, it's every 10 weeks is you give them the shot. They have to be observed for 30 minutes for pulmonary oil microembolism. So I don't know that that's anything I really want to deal with.
Yeah, that's for sure. I'm curious, what is the concern about hepatotoxicity with the oral form of undecanoate? Have they looked at that?
They tell me according to the company, it bypasses the liver and it's absorbed in the lymph system, and there isn't any.
Okay, yeah.
That's if you can believe them.
Right.
Sure. And as we've seen with others, I don't know about whoever is making the undeconate, but as we've seen with other big pharma companies, they don't always tell the truth. So I would research it before we start using it. And again, these are really expensive. I mean, cypionate, you can get that for $20 a month. And I don't know where you are, but I mean, the CVS here is ridiculous anymore. They'll only give out 1 milliliter bottles. They tell the patient as soon as if they put as soon as they take anything out of it, they have to throw it all away after 28 days. And they won't let me write it for a 10 milliliter bottle. So and then they don't have it half the time. So here I told you this already. Cypionate 12-day half-life, ethynate 10.5-day half-life, propionate 36-hour half-life. You can combine them. You can put propionate and one of the others in the same syringe. That's what Dr. Gordon does for his head injury guys. You can do anastrozole and HCG in one syringe. There's that big push to not use aromatase anymore. You can put zinc in there. And anastrozole. You can even have a pellet made with testosterone and anastrozole also. And usually you need a 0.5 to 1 milligram a week is the usual dose for that. Side effects you can get labile mood swings, especially towards the end of the 7 to 10 day period. The symptoms of testosterone deficiency can return. You get more erythrocytosis with the injectable than you do with the transdermal. I think the rate's it's 43.8% for the injectable and 15.2%, I think something like that, for the cream form for erythrocytosis. Acne, you get skin breakout on the neck and shoulders, and oily skin, oily hair, redness in the face. You get peripheral edema, and blood pressure elevations. Those are the things to watch out for. Excess estrogen, you get the man boobs, gynecomastia, and the alleged cardiovascular issues, but we've already gone through those and showed you that most of those are not true. Pellet dosing, we're going a little bit higher now. We're going about 1,400 to 1,800. I've seen them as high as 2,400. We get the compounded doses, pellets. We usually get 200 milligrams for guys and 100 milligrams for gals. Gals about 1 milligram per day, guys 10 milligrams per day. So if you do 7 200 milligram pellets, that's 1,400 milligrams. It should last about 140 days. Some guys it's less, some guys it's more, but that's about average. Women, there's a little bit more of a swing, and usually that only lasts 3 to 4 months. So I've gone as high as 225 milligrams in a pellet for women, but the usual is about 150. If we're starting somebody new and when their levels are low, when you start somebody new, if you use high doses, you're going to see side effects. You're going to see the oily skin and skin breakouts and chin hairs. So start lower. You just tell them we're going to start low. After 2 months, if it seems like it's wearing off and it's not lasting, I'll usually give them a cream to get them out to 4 months instead of repelleting. 1,200 milligrams for guys is a good place to start. There are websites. If you go with like a Vexapel, they'll tell you to put in all the parameters, the total testosterone, the free, the sex hormone binding globulin, and the albumin, and they'll spit out a quote unquote exact dose. It usually comes out to be the same. Then testosterone without enhancement. I'm gonna have to get going. It's 20 after. So can we stop here?
Absolutely, sir. Yes, sir.
And we'll pick it up next time. We'll start here at clomiphene. Okay.
That's perfect. Yes, sir.
Sorry, I have to be at the office in 40 minutes. I have to get ready.
Oh, thank you so much.
Okay. All right. Say hello to your lovely bride, and we'll take it.